Thank you, Professor Brown, for that outstanding and very thought-provoking presentation. Our next scheduled presenter is Dr. Bornstein. She is the Assistant Professor of Radiation Oncology, working with Dr. Fomenti at the Weill Cornell Medical College on clinical trial development combining radiation and immunotherapy. She is speaking in place of Dr. Fomenti regarding developments in this field as related to the immunomodulatory effects of breast radiotherapy. Dr. Bornstein? Thank you very much.
Hi, good morning. How are you? I'm here in place of Dr. Fermenti, so keep your expectations modest. I'm in her group. I'm fairly new working with her, but it's been very exciting to sort of be inspired by her and her motivation towards expanding trials that combine immunotherapy and radiation. So I'll talk a bit about that and some potential implications for IORT with this. And Dr. McKee already went over a lot of the stuff that kind of pertains to the talk, so hopefully this will be sort of reinforcing some of that. So just as a brief overview, it's been known for many years that the immune system has a natural ability, sorry, I can't see the slides, to recognize and kill cancer. And normally the immune system ignores our cells because they have markers that show that they're part of our own body, part of ourself, and this is important to prevent autoimmune conditions. However, when normal cells become cancer cells, they present these foreign molecules, and this is called antigen presentation, and these basically cause the immune system to attack the tumor. And so these markers can be expressed by the microenvironment in the tumors themselves. And unfortunately, if this worked, we wouldn't have cancer at all, but often the immune system shuts down prematurely. And if it doesn't shut down prematurely, then it's ineffective. And this has a lot to do with the cancer cells and the immune cells in the microenvironment expressing these molecules that basically say that I'm still you, don't attack me. And these are molecules like PD-L1 and CTLA4. And so basically, once that was discovered, we had these groundbreaking sort of achievements with the advent of checkpoint blockade. And so these blocking these sort of immunosuppressive pathways has really kind of been a paradigm shift in cancer treatment, and these are usually much better tolerated treatments and have improved survival over chemotherapy in a lot of cancer settings. And this is just a cool picture showing a T cell attacking a cancer cell. This is very exciting. However, the case is that the majority of patients do not respond to checkpoint blockade. And so we're very much trying to figure out why that is, who responds, who doesn't, and how do we help sort of improve this response rate. So this was an interesting paper that came out in the JCO looking at two adjuvant trials from ECOG, looking at triple-negative breast cancer patients, and basically just looking at their H&E slides at baseline, and just looking at infiltration of lymphocytes, that's it. And it was very interesting that just with sheer numbers of lymphocyte infiltration, that seemed to very much impact prognosis, such that for every 10% increase in the stromal lymphocytes, there was a 14% reduction in recurrence or death. So just using this simple metric, it's very clear that even just the numbers of lymphocytes can be helpful. And to this end, we and other groups have shown that radiation can basically cause an immune infiltration through a type of cell death called immunogenic cell death. which sort of wakes up the immune system to some extent and can just lead to more inflammatory tumors. And so we think this is one of the very simple mechanisms by which radiation can help increase this response rate. One of the things that's been of interest of our group in particular is the ability of radiation to not only help with local response, but also response to distant sites in the setting of metastatic disease. And this basically just shows what that looks like. So we all know when you treat with radiation, you can affect the local area and achieve local control. But the abscopal effect is basically when you see a response in an area that has not been radiated. And this has been around since the 50s. Our group has basically demonstrated over many decades of careful preclinical work that this is an immune-mediated effect of radiation. Basically this figure shows very complex sort of mechanisms that have been sorted out regarding radiation and this type of immunogenic cell death. And Dr. Fermentes basically coined this phrase in situ vaccine. So basically that radiation creates a vaccine in the area of the radiated site that then primes the immune system to act elsewhere and basically, in certain cases, create a complete response to radiation. So this is just another case report. We saw some yesterday with Dr. McKee's talk. This is from our group. Just an example. This patient had chemorefractory lung cancer. Basically, no other therapies could be offered. He failed several lines of therapy and had disease in his liver, his lung, and his bone, and as demonstrated here on the PET scan. And so we got approval to use compassionate use of, in this case, ipilimumab, which is a checkpoint blockade molecule, and then radiation, 6 gray times 5 to one of the liver lesions. And the patient achieved a complete response. And is now 4 years out from treatment, still without any other therapy and no other disease. So these are very inspiring to us because, you know, chemorefractory metastatic lung cancer used to be just a death sentence. And this inspired, in this case, a study that was started at NYU and now we're at Cornell, looking at this in a phase 2 setting. And this Simon's two-stage design that we use is basically designed to assess abscopal responses, or it's not designed for that, but it's very helpful for us in evaluating this. And so just preliminary results from this in a larger population of patients. It's shown that basically the response rate for people completing all the courses of the ipilimumab is 33%. And also disease control rate for that group is over 50%. So this is, again, very encouraging so far. So just to kind of summarize this portion of the talk, in general, we see about doubled response rates to checkpoint blockade when we add radiation, and a few complete responses. Our next step is to combine this with both ipilimumab and nivolumab, so dual checkpoint blockade with radiation. And now there's over 80 clinical trials looking at different combinations of immunotherapy, not just checkpoint blockade, but there's many other types with radiation. This was a recent systematic review done about the abscopal response, and basically there was only 46 cases if you look back from sort of when it was first defined. And so sort of one question is, why is that? Why are we seeing so many more responses now? And I think outlined the combination with checkpoint blockade as one of them. But also, if you look back at these studies, this was also before the advent of SBRT. And a lot of these were very wide field, protracted fractionation courses. So I'm going to talk a little bit about sort of what we think is important in terms of this in situ vaccine. So we feel that, there's certain things like histology, the genetics of the patient themselves that play a role, and that's being looked at. I told you just, infiltration of lymphocytes is important. But some of the things that we focus on are the dose and fractionation of radiation, which is very important for this. I'll just talk a little bit about that. What I just touched on, which is the volume irradiated, and then also the microenvironment. So we do know that it's not just a number of lymphocytes, it's a complex dynamic sort of composition of not only lymphocytes, but macrophages, different types of T cells, natural killer cells, and all of those can be affected by therapy as well as radiation. And so just to kind of touch on some of this, and this was mostly done by Dr. Fermenti and Dr. De Maria, which are just really inspirational figures. And it's a very active group of, kind of being in the lab and also in the clinic. And so it's been really great working with them. So again, immunogenic cell death is what we sort of focus on. And this is this, again, type of death where it triggers the immune response. And this was discussed a bit yesterday, but we've sort of used these 3 molecules to be sort of representative of that response, although of course it's a lot more complicated than that. So the release of ATP and HMGB1, as well as calreticulin self-surface exposure, are 3 that we sort of assay for when we're assessing, whether or not this response is actually going on. And these lead to dendritic cell priming, which leads to effector T cells that can then go elsewhere and try to kill tumor cells. So this is, again, a paper that came out of our group showing these 3 sort of fluorometric assays that are very easy to do. So, for any preclinical efforts that anyone wants to look at to see if your drug or radiation dose causes immunogenic cell death, these are very easy assays. And one thing to point out, which was brought up yesterday, is that immunogenic cell death is dose dependent, and it's in terms of fraction size dependent as well. So some of the previous, 1.8 gray per fraction doses of radiation would not necessarily trigger immunogenic cell death, or likely not. And so that's part of why we see more of this now. Also in this paper, we found that immunogenic cell death from radiation was enhanced by chemotherapy, certain chemotherapeutics in particular. We looked at platinum and paclitaxel. This was also in a dose-dependent fashion. And so Dr. Fermenti has done 2 studies using this notion. So she did a study with neoadjuvant treatment of paclitaxel and radiation in locally advanced breast cancer patients. This was a multi-center trial, and there was a 34% pathologic complete response in the breast and the lymph nodes. And based on some of the preclinical work and the work done with these patients, it's thought to be due to enhanced immunogenic cell death. So not using immune checkpoint blockade, but just using regular chemotherapeutic agents that are associated with immunogenic cell death. Also in the adjuvant setting, interestingly, so stage 1-2 triple negative breast cancer patients were treated after surgery, prospectively with weekly carboplatin, one of those agents that causes immunogenic cell death with radiation, together with, in this case, this was prone radiotherapy to the breast. And these were very promising results with, at 48 months, 94% alive and disease-free. So this is of interest to our group in the absence of checkpoint blockade. And a lot of the protocols sort of combine just regular chemotherapy used in a certain specific fashion, and also checkpoint blockades or other immunotherapies. So it's very much an evolving field. The other area I wanted to bring up, which I touched on, is volume dependency. So one thing we know in terms of this immunogenic cell death is that you need naive T cells to be able to be primed to go out and to unirradiated sites to cure cancer. But if you radiate too large of a field, you don't have enough of these naive T cells. We all know they're very sensitive to low doses of radiation. So it's very known that a lot of types of cancer, like glioblastoma or pancreatic cancer, excuse me, sorry, I have a cold. After these long courses of radiation, they have severe lymphopenia. And this has been looked at by Johns Hopkins group, looking at lymphopenia after radiation and showing that basically, in order to avoid this, you need to use a small PTV, high dose rate, and basically hypofractionated radiotherapy to try to get around some of this high volume of radiated naive lymphocytes. And this was also looked at more recently in pancreatic cancer, where we're using SBRT in unresectable cases. This group compared that to conventional chemo-RT for pancreatic cancer, which, as we know, includes a lot of lymph node regions, and basically showed that this lymphocyte-sparing effect of SBRT, that lymphopenia was dependent on the size of the PTV irradiated, as well as the number of fractions. And SBRT on its own led to reduced lymphopenia, and also this severe lymphopenia was prognostic for survival. So we know, I mean, it's pretty well established now that this is very important, and not only we think for priming this abscopal responses, but also just survival on its own. And so, we would argue that blood itself, or the amount radiated, is an organ at risk in this setting. And then lastly, microenvironment dependency. So, and this has been touched on throughout the conference, and relates to sort of intraoperative radiation, that immunosuppression really dominates when there's an established tumor and also after it's removed. And this has to do with inability of the tumor cells to present antigen, increased TGF-beta, checkpoint inhibitor, checkpoint molecules like PD-L1 that gets upregulated, CTLA-4. All of this sort of leads to sort of a immunosuppressed state that's tumor promoting. And we also know that in general, radiation sort of has a positive effect on triggering immunogenic cell death and tumor rejection, but at the same time, it also has negative effects on the immune system and creates some level of immunosuppression at the same time. And that's through direct upregulation, basically, of TGF-beta and PD-L1, so that's well known. So we have to try to figure out a way to time this and deal with this issue as well. Recently, we published a preclinical study looking at TGF-beta in this setting, and the title is, it's a master regulator of radiation therapy-induced anti-tumor immunity. So as I mentioned, radiation upregulates PD-L1 and TGF-beta, and this is thought to sort of damper its ability to create this in situ vaccine. And this study basically, in breast cancer mouse models, showed that when you inhibit TGF-beta, you had increased sort of survival and response rate of the mice, and that PD-L1 was actually an escape mechanism for this, so that if you combine both TGF-beta and PD-L1 inhibition, you had drastically improved outcomes with this preclinical model. And this has also been reflected in the clinic. This hasn't been published yet, but Dr. Fermenti did a trial with TGF-beta blockade in chemorefractory metastatic breast cancer patients in a multi-center fashion. And frezolizumab is the TGF-beta blocking antibody. They received radiation to a single metastatic site. And this had very promising results, so we feel like this is actually happening in patients. And it will be very interesting to see if the addition of PD-L1 or PD-1 blockade will further augment this response rate. So just to sort of come to the end of the talk, implications for intraoperative radiation. So intraoperative radiation is interesting because it has sort of this high dose that we feel is important potentially for immunogenic cell death or other effects on an immunosuppressive microenvironment, but also sort of a low volume of treated tissue. And so this does fit into this, what we would think would be an appropriate radiation modality to help overcome an immunosuppressive microenvironment. And so I think it would be really interesting to sort of see how we could use intraoperative radiation now that, as discussed, we're moving into more high-risk patients to not only affect the local environment, but maybe even primary immune response. And so this could kind of be applied to high-risk early stage, but even, we've been treating second breast conservation patients, or even more advanced patients that we wouldn't normally treat with IORT. And so preclinical work that I think has been already sort of touched a bit, but we're also interested, our group is very interested in as well, is how to best direct this sort of therapy or combination of immunotherapy with radiation. And as we know, the lumpectomy does create this immunosuppressive microenvironment, and this is reflected in the wound or seroma fluid. And we know that some of the adverse sort of signaling that goes on has to do with these wound healing pathways gone awry. And so, a paper that was already discussed that this, wound fluid can stimulate migration and proliferation of cancer cells. And our group has shown that seroma fluid from malignant lumpectomies compared to lumpectomies done for benign reasons has altered cytokines. So, as you might expect, GRO, TIMP2, leptin were upregulated in malignant seroma, whereas these other molecules were downregulated. So this is just hypothesis generating. We know that wound responses in breast cancer are associated with local recurrence and reduced overall survival and distant metastasis-free survival. One potential way this could work is through the transition that cancer cells undergo to a more mesenchymal phenotype in this setting called EMT. And this is potentially involved in metastasis and as well as a form of immunoediting or immune evasion. So ways to overcome that are of potential interest. And there's some evidence that IORT may have that promise. So I think it will be interesting to potentially collaborate further with studies to characterize this wound fluid, both the immune infiltrate that may be there and the cytokines that may be there, and also compare this to sort of the peripheral immune phenotype as has been discussed, and maybe figure out, which of these cytokines or cell infiltrations are actually important for recurrence now that we're looking at more high-risk patients. And then see if there's some sort of potential targetable biology. There's a lot of inhibitors now, not just to checkpoint blockades, but as I mentioned the example of TGF-beta, but also things getting at macrophage polarization or Treg infiltrate. So, there's a lot of things that could be explored. This is all sort of in the future, but I think it's very exciting. So thank you for having me here to talk. Sorry about my cold. I'd like to thank the whole group, Dr. Fermenti, Demarian Golden, and Claire's work I talked about the most, but there was a lot of work that came well before I came there. And thank you to the Target Collaborative Group for having me here to talk in her place, and looking forward to collaborating if possible. Thank you.